Hi, it's Dana Dunne. I'm one of the faculty members at the Yale School of Medicine Infectious Disease section, and today I'm going to talk to you about bacterial sexually transmitted infections. I also serve as the clerkship director, and any of my students can tell you anytime that I have an opportunity to talk about STDs, I will. So just going to talk about bacterial STIs today, and specifically we'll update you about the epidemiology of chlamydia and gonorrhea, including Mycoplasma genitalium, and a little bit about syphilis, especially with respect to interpreting serologies if you're one of the institutions that's using the reverse screening algorithm. So we'll start with a case, and we have 3 cases today. So this is a 24-year-old male graduate student presenting to your office with complaints of 7 days of terminal dysuria. So it's really irritating him right when he starts his urine, and he's looking as worried as Kermit the Frog there. So the questions you're going to be thinking about as we go through this stepwise approach to urethritis is, what else would you want to know from his history that's going to help you determine whether it's sexually transmitted at all, and if so, which organism? Really, what is the differential diagnosis? And what do you test for, and where in the body do you test from, and who would you treat empirically? And if you're going to treat empirically, what would you use? So nationally, with respect to the proportion of urethritis in male urethritis etiologies, it breaks down to about 20% gonococcal and 80% non-gonococcal. You can see the breakdown there of what etiologies that are non-gonococcal are chlamydia, ureaplasma, mycoplasma, or trichomonas. These ranges that you see there can vary depending upon the age of the patient and even what country they're from. This is the U.S., but for example, in Mycoplasma, genitalium is probably the most common cause of NGU in Spain. Note the unknown category there, which includes things like having received oral contact with a patient's penis being in contact with a partner's mouth, so it's thought that maybe salivary amylases or bacteria might be in the urethra transiently. Other etiologies of unknown urethral inflammation include being atopic during hay fever season, or having reactions to chemicals, like if their partner uses a douche or other chemicals. So I did want to also include a little bit about Mycoplasma because a PCR test just got approved. So you might wonder how common Mycoplasma is in the general U.S. We have Nahane's data shown here on the left, where it shows that in men and women it's not as common in asymptomatic men and women as chlamydia, but it's more common than gonorrhea. And in STD settings, when men are coming in with symptoms of urethritis or women are coming in with symptoms of cervicitis, it is quite common and is right up there with chlamydia and gonorrhea. And it has been independently associated as a cause of urethritis, cervicitis, and PID, and now we have a test for it. So for your urethritis stepwise history, I'm going to tell you about 7 steps. And step number 1 is to always take a complete sexual history. You need to remind your colleagues about this as well when they're referring patients to you. You can allude to the CDC's recommendation of the 5 Ps, which is asking about partners, practices, protection, past history, and pregnancy. And these things get at you're determining whether or not people have enough of a risk factor to treat them empirically when we get to that step, and possibly, depending on the answer to some of these questions, which etiologies may be more likely. So don't forget to ask about numbers and where they're meeting their partners. You want to make sure you ask things about when the last time they had unprotected contact, because gonorrhea incubation period can be very fast as compared to Mycoplasma or chlamydia. Gonorrhea can be an incubation period of anywhere from 12 hours to up to a week, so it's shorter, whereas chlamydia and Mycoplasma is typically more like 7 to 21 days. And you really want to ask them where in their body they've been exposed so that you know where to check them. Whether they use a condom or not is a risk factor for testing positive for a bacterial STI, as is past history of STI. And we really want to find out what women are doing to protect themselves against pregnancy. So they should always routinize the sexual history on everyone, especially somebody coming in with symptoms. So step number 2 is that you should really assess for the presence of urethritis. He's complaining of irritation, but he may or may not have objective evidence. You can do that in one of 4 ways, either looking to see if syndromically they look like they have discharge coming from the urethra. On this first panel, you see something that looks a little bit more mucoid compared to the picture on the right, which you can appreciate is more purulent and more consistent with something like gonococcal urethritis. So the syndromic approach would just be to say that they have urethritis because you can see pus. Sometimes it's not as clear, and so using a gram stain with now a new cutoff of more than 2 white cells per oil field is being consistent with urethritis. So you can see here 16 white cells or so with no intracellular organisms, and the beauty of doing a gram stain to assess for urethritis is, in addition to being able to see if they have inflammation with more than 2 white cells, you can see if there's intracellular gram-negative diplococci, as you can see there on the right, inside those white cells, so you have a diagnosis of gonococcal urethritis in a stat setting. If you don't have access to gram stain, you can spin down a urine and pour off the sediment and see more than 10 white cells per hydride field. Or if you have neither stain nor microscope, you can dip the urine, and with the biochemical dipstick, anything more than 1+ leukocyte esterase would be consistent with urethritis. So you've taken a sexual history, you've confirmed that they have urethritis, and then you want to send your diagnostic tests. So everybody who's complaining of symptoms should have a test sent. Most of these tests are now molecular. I do list here a few indications for when you'd want to try to obtain culture, but they're really far in between. Chlamydia, in some medical legal situations, a cell culture might be useful because it's going to be more specific and there will be no false positives with a cell culture. But most rape kits and other sexual assault kits have chlamydia molecular testing in them. And the other setting in which you might need to use culture is if your site has not had extragenital nucleic acid amplification tests approved. Otherwise, we really do rely on molecular tests for both chlamydia and gonorrhea, as well as the new Mycoplasma genitalium nucleic acid amplification test. So GC and chlamydia have 3 methods that are out there on the market, 3 different branded tests, which all perform a little bit differently. But I can tell you that the bottom line is for chlamydia, gonorrhea, and mycoplasma, the most sensitive sites to send from for men are in the urine or urethral swab, and men certainly prefer a urine test. And for women, a vaginal swab, either clinician-obtained or self-obtained, is more sensitive on average for chlamydia, gonorrhea, and mycoplasma than is urine or even endocervical. So if you have not are able to have an opportunity to do a pelvic exam on a woman, don't send them in for a urine test. Send them in with a self-obtained vaginal swab, and it increases your yield for chlamydia and gonorrhea and mycoplasma. The mycoplasma test was just approved in January 2019 and is available commercially in many large commercial labs and may be available in your hospital. I'll just say parenthetically, there's no screening recommendations for mycoplasma yet, but it's available to send in your patients who have a complaint of urethritis. The 4th step is to determine whether or not you think you need to treat somebody empirically while you're waiting for their test results to come back. So this is really taking together whether or not they had risk factors that I alluded to before. The 4 risk factors that would predict whether or not somebody's going to test positive for a bacterial STI is young age, inconsistent or non-existent use of a barrier contraceptive, a history of an STD, or new or multiple sex partners defined as within the last 60 days. So do they have risk factors, and do they have objective evidence of urethritis, which was step 2, and also to think about whether or not they'll return for treatment. So you can see there at the bottom, I've put together some things for your consideration, that if they have risk factors and objective evidence, especially if it's low likelihood that they're going to return, you should think about treating those people empirically. Whereas if somebody has no risk factors, but they're complaining of urethral inflammation or discomfort, and you don't have a lot of objective evidence, especially if they're concerned and they're likely to return and they're likely to be abstinent while they're waiting, it's totally fine to wait. So that's how you would kind of put together your history and your risk factors to decide whether you would treat. So once you've decided whether you're going to treat empirically or not, you have to decide if your empiric treatment is going to be for non-gonococcal urethritis or gonococcal. So you're going to make that decision based on the prevalence of gonorrhea in your area, if the clinical features like the way the discharge looks or how short the incubation period was will tilt you more in favor of treating for gonorrhea. Whereas if you have minimal symptoms, scant discharge, not a lot of gonorrhea in your area, the likelihood that you'll have to include gonococcal treatment right up front is going to be lower. So if you're going to go with NGU, what's the empiric treatment regimen? It is azithromycin, so I like to say a gram for the clam. You use 1 gram of azithromycin once, or you can use doxycycline for 7 days if somebody has an inability to take azithromycin. I wanted to mention for NGU, if you're concerned about Mycoplasma to genitalium, either because somebody has persistent symptoms, if you use doxycycline, or if you are reacting to a positive Mycoplasma genitalium PCR, the drug of choice is azithromycin. The cure rate with doxy is only in the 30 to 40% range. So the drug of choice would be azithromycin, but there's emerging cases that are not responding to azithromycin, and your second level of drug choice would be moxifloxacin for a week. But even with that, in places that see a lot of MGen, like Europe and Australia, they're seeing a lot of emerging resistance even to moxifloxacin. So a gram for the clam, otherwise typically we'll get both Mycoplasma and Chlamydia. So the step that I wanted to make sure that as ID clinicians you remember, because it can be something that a lot of your people who are consulting you forget, and you might as well, is to don't forget to report. We do dual reporting in the state of Connecticut where the lab does report, but you're supposed to report as well. So reporting includes an STD-23 form, which I'll show you on the next slide. But if you want to also avail yourself of partner notification services, I have the phone number there for you. Lastly, I would say that it is legal in Connecticut to do something called expedited partner therapy, which allows you to either call in or write a prescription for up to 4 extra prescriptions if you have partner names for the index patient, so that it will decrease the likelihood that your index patient that you're treating will get reinfected from an untreated partner. So it allows you to really offer treatment to partners even though they're not patients of yours. And there's more information at the website that I list there. This is the form that you or somebody in your office has to fill out that really gives us more enhanced information than just the lab reporting form, which just has a name and what they were tested positive for. This has more nuanced information about the disease and if you treated it and with what. So let's move on to the second case. Somebody coming in who's asymptomatic. He's a man who has multiple male sex partners, and he wants you to screen him for STIs. So the 2-part question is, what do you send? And the second part is, what else can you do to keep him healthy? So just don't forget to ask him about where he's been exposed, because not all chlamydia and gonorrhea comes out the urine. If he's had oral contact with his partner's genitals, or if he's a bottom partner for anal intercourse, you're going to want to make sure you get swabs from all sites. Otherwise, you won't find any asymptomatic chlamydia or gonorrhea, which is quite frequent, gonorrhea in the throat and chlamydia in the rectal area. So please swab all exposed sites. Don't forget to test for HIV and syphilis. It's debatable about whether you'd get herpes simplex serology, and we won't go there for right now. But don't forget to update them against bacterial or viral hepatitis infections that are vaccine preventable for both hepatitis A and B, to offer them about HPV vaccine, which is now approved for use up into the 40s for both men and women. And don't forget to have the PrEP discussion and start him on once daily therapy to prevent HIV acquisition. So you screen him from everywhere, and his gonococcal swab from the pharynx comes back positive. So you sent a chlamydia and gonorrhea swab to a lab that's been validated to do nucleic acid amplification testing from the throat, and it's positive. So this is really getting at the fact that gonorrhea now has superbug status according to the CDC, and they're really concerned about multi-drug resistant gonorrhea. And therefore, even if you have ruled out chlamydia, the CDC would like you to use dual therapy for gonorrhea. So the azithromycin that you're using here, in addition to the ceftriaxone, is not for co-infection with chlamydia. It is to make sure that you're double covering in case there's a ceftriaxone-resistant strain that washes out onto our shore, that there are still some gonococci that are susceptible to the macrolides, so we're using dual treatment. So if you have a beta-lactam allergy, we used to give 2 grams of azithromycin, which still is an option, but the CDC would prefer that you not use it because of concern with emerging resistance. There is some small data with using either gemafloxacin or a large dose of gentamicin with 2 grams of azithromycin for those patients that have beta-lactam high-grade allergy. If you're not dealing with a pharyngeal infection and you're only dealing with anorectal infection and you don't have an injectable cephalosporin, you can use cefixime orally along with the azithromycin. So take-home points about this section would be to remember that Mycoplasma, Chlamydia, and M. genitalium, along with a few others, all affect the urethra and the cervix. Chlamydia is more common than the other two, and gonorrhea can sometimes be clinically distinguished, but not reliably so, by having a shorter incubation and more significant symptoms. We're double treating gonorrhea, and for all of them, and trichomonas as well, I'll add that because partners can get reinfected, that we really want you to rescreen for chlamydia, gonorrhea. Mycoplasma genitalium is not officially recommended to rescreen, but trichomonas as well. Test people again in 3 to 4 months to make sure they didn't get re-exposed. So moving on to our last case of somebody with a genital ulcer. This is a 30-year-old coming in with 7 days of a painless ulcer, and there is a differential diagnosis, but not all the things on this list are really possibilities, as you hopefully will appreciate. But I wanted today to really talk about syphilis. Just a couple of epidemiology slides just to remind you how the rates have been really going up, especially in men, since about 2001. The male to female ratio peaked a few years ago at 16 to 1 and is coming down a little bit, but the male rate continues to climb, and it is starting to go into women with bridging populations as well, and that's also affected an uptick in the number of congenital syphilis cases as well. So syphilis is on the rise, especially in men who have sex with men, and is a little bit on the rise in women as of the last couple of years. So this slide just shows you that risk factor compared to men who exclusively have sex with women, and that's what has led to the U.S. Public Health Service Task Force to recommend making sure you've taken sexual histories in your patient, and if you have men who have male sex partners, to screen them for syphilis. This is beyond the scope of this talk to give you a lot more information about syphilis, but I would just remind you with this slide about the stages, and I especially want to call out the timeline shown in that graphic in the bottom corner to remind you that even though we talk about neurologic disease, typically when we talk about late syphilis, that there's early neurologic involvement when people get exposed to syphilis as early as when they have their chancre, and definitely by the time they have secondary disease. You can, if you do lumbar punctures on those patients, find evidence of early CNS involvement. So most is asymptomatic, but you can get some symptomatic neurosyphilis even during your secondary syphilis stage or right about that time. That's called symptomatic early neurosyphilis, and we're seeing a lot of that over the last 5 to 10 years, including ocular syphilis, otic syphilis, cranial nerve palsies, and meningitis, aseptic meningitis. And I was alluding a little bit to the fact that we have been seeing a little bit of an uptick in congenital syphilis cases as well. So that's a real super quick overview of the stages of syphilis, and I just wanted to remind you of the fact that you can get early symptomatic forms of neurologic disease right before somebody might present with secondary or during. But what I mostly wanted to spend time talking about was diagnostics, because some labs have switched the order in which we do syphilis serology, and you get called a lot about interpreting syphilis tests. Though the overview is just to remind you that there's direct and indirect ways of testing for syphilis. The direct methods are dark field, but decreasingly available, and you've sometimes maybe have had skin biopsies tested for either with monoclonal antibodies that are fluorescein tagged or with silver stain where you can see the spirochetes in direct tissue. But otherwise, we really typically rely on blood testing and looking for antibody responses. And the blood tests come in two flavors, the non-treponemal tests and the treponemal tests. Historically, we had started with the non-treponemal tests, the VDRL and the RPR being the prototypes, and there was about 10% false positives when you would test starting with a non-treponemal test, because it's just a test looking for antibody to cardiolipin, which would be seen in syphilis but could also be seen in other diseases. So, our algorithm used to be, those are just some slides showing you how syphilis would look under a dark field scope or under tissue staining. But our traditional screening algorithm had been that we would start with the non-treponemal test, and if it was positive, we would reflex to a specific treponemal test so that we could confirm the reactivity we saw from the RPR, the VDRL, was actually from syphilis. So you'd start with the RPR and reflex to a specific treponemal test. That worked well for a long time, but a limitation always with it was that the biologic false positive rate, as I had mentioned with the non-treponemal test, is about 10%. You multiply that by all the tests that get sent in pregnancy as per guidelines, and you have a lot of tests that then have to be reflexed because of all those false positives. And the treponemal tests, at least the ones that we've used for a long time, like the TPPA, are very labor-intensive and expensive to do. So there's been a lot of interest in coming up with an automated treponemal test. So we have now are in the era of what we call a reverse screening algorithm, where we now start with these automated specific treponemal tests. You might use an EIA or a CIA. They're all automated and they are specific. But since they don't give you any quantitative measure of how active the disease is, now we do the reverse and we reflex to our non-treponemal tests, which were while they were non-specific, they were quantitative. So if the titer was quite high, we would use that to test response to treatment. So what you end up getting called on is when you have discordant results. And I would recommend this publication that kind of outlines some of the numbers behind this. But if you start at the top of the flow chart, you would start with a treponemal screening test. And if it was negative, it's very highly sensitive and specific, and you would be able to be done. And 97% of tests that get sent nationally are negative. But if it's positive, that's when then you reflex to the RPR. And if it's positive, then you're in the same position that you would have been with the older test, that you'd had a positive RPR that got reflexed to the old-fashioned TPPA, and it was positive. If both are positive, you've confirmed that they're seroreactive to syphilis. And just like you used to be in the past, you still have to figure out with your own history and physical what stage the syphilis is. Is it primary, secondary, latent, etc.? But what has caused some consternation is if the screening treponemal test is positive but your RPR is negative, that discordant reaction now has a tiebreaker test that gets sent, which is the TPPA. That's our old-fashioned, original, expensive, labor-intensive treponemal test. So if you have a discordant screening test and your RPR is negative, the tiebreaker test is the TPPA. If that's negative, your initial treponemal screening test, the EIA or the CIA, was probably a false positive. If it's positive, there's 3 different reasons for why that RPR might have been discordant. One reason is that they could have old treated syphilis, and that means the RPR became negative, but the TPPA and the EIA stay positive for life. Or it could be old untreated syphilis, because we know up to a quarter or more RPR seroreactivity will spontaneously become negative even without treatment. Or it could also be very early syphilis, because treponemal tests turn positive earlier than non-treponemal tests. For the latter, if you're highly suspicious of somebody who's in a high-risk group, it's recommended to repeat the test in a couple of weeks. Otherwise, the way you'll find out the difference between whether somebody's got old treated or untreated syphilis is that you can either ask the patient and or you can call your local health department at the number I have at the end to see if they're on record of ever been treated. If they have, it's probably evidence of old treated syphilis. If they haven't, you should treat them according to stage, which is often late latent disease. But this is really where you and your fellows will get called to help you interpret these discordant results. And you'll have time best well spent if you can talk to your lab to put all these things on their reporting with explanations, and they can call you if there's still any confusion. These numbers are just to say, in the large hospital studies, 97% of the initial tests were negative, 3% were positive, and you can see as it goes down the line that at the bottom, 32% of the TPPAs that were negative down there at the bottom meant that really 32% of the initially positive EIAs ended up being false positives. So that gives you an idea of how often this happens. Some treponemal tests have lower false positive rates, and those are all published. So if you have a positive test, just remember you have to use your history in your exam to stage the person. Don't forget to do an HIV test. You're going to treat them according to the stage that you determine that they have with penicillin. And don't forget to fill out that STD23 form, and you're going to want to follow up their serology every 3 months until it's negative or stable and low. So last thing I want to cover is just partner notification. This is something that a lot of us forget to do, and it's really been difficult in the era of finding hookups through Grindr or online to find partners when patients don't necessarily know how to get a hold of them. So this is an example of a email program called InSpot, where if the patient knows the partner's email, they can pick from any variety of STI that they might have exposed the person to and send them an email, and it sends them, according to what city you're in, even links to where they can get tested and treated. So that's great. And some of these World War II posters have now been updated to remind people about STIs, and I'm just reminding you here with that phone number, 860-509-7920. That's our Department of Connecticut STD partner notification line. So if you need help with finding patients and getting them their partners treated and in for treatment, you can call that number, and they'll help interview your patients and find your patients. So don't forget that form. So bottom line messages, don't forget to routinize the sexual history taking so that we can know who's at risk, and it can help you with some of your clinical decision making about empiric treatment and with what. It is really important to keep up with the epidemiology so we know in what group people are having upticks in rates of some of these STIs. You have to screen all sites that are exposed because not everything comes out the urine. Most STIs are asymptomatic, so being led in your testing just to test people where they're symptomatic will underdiagnose a lot of sites that could be infected and be asymptomatic. We're double covering for gonorrhea at this point. Don't forget to ask your patients if they are men, if they have male sex partners, so we can make sure we screen them and also get them into other vaccines and strategies like PrEP that can prevent acquisition of other STIs. And partner notification is a missing link for a lot of us. We have a lot of help at the state level. And I wanted to put a plug in that there's a national coalition where if you have a tricky syphilis case or resistant mycoplasma, there's a national coalition of STD clinical prevention training center providers that will get back to you in a day or two about your clinical question. And the app that the CDC has for all the treatment guidelines is also free and up to date. Gets updated frequently, so there's always something that's in your pocket. And for everything else, I also put the Connecticut DPH website on here, including their phone number. We have a small state. There's not that many disease intervention specialists, and they're there to help you with partner notification, especially for new HIV cases, syphilis, and gonorrhea. I really would love to help you with any syphilis cases, so feel free to email me.